Now let's talk about coronary artery disease or CAD. So CAD is any one of the abnormal conditions that can affect the arteries of the heart and produce various pathologic effects, especially a reduced supply of oxygen and nutrients to the myocardium or heart muscles. So there are risk factors for this. So patients who are or have the following characteristics. Now, there are non-modifiable and modifiable risk factors. So know that the non-modifiable are things that the patients can't really control or choose. And then you have your modifiable, which can be changed or controlled to prevent the development of CAD. All right, so let's start with your non-modifiable. So age. So people who are age 50 or older than 50 are at a higher risk for developing CAD. Women after menopause, Black Americans, men are at a higher risk compared to women, and then genetics, especially if hyperlipidemia or high cholesterol levels run in the family. So those things we can't really control, right? Because once you age, I mean, it's not like you can turn back time. I mean, and also if you're born a woman, once you reach menopause, so those are the things we can't really control. So those are your non-modifiable risk factors. Now you have your modifiable risk factors. So these are the things that can be prevented or controlled to prevent the development of CAD. Examples of this include diabetes, hypertension, and elevated cholesterol. And some people would argue with me about, well, if they already have it, it's not like they can really control it. Well, I can understand where the confusion is coming from, but when you really look at the diseases, many of these diseases are really can be modified through a better lifestyle by eating right and exercising. So these are modifiable or things that can be prevented or controlled, even for a patient with diabetes, right? Again, if they take their medications, they watch their diet, for the most part, they can control that disease. Now, if they don't take care of themselves and they start eating a lot of carbohydrates, they don't take their medications, and then, well, then it can be out of control, which increases their risk for developing CAD. Other modifiable risk factors include elevated LDL, which is your bad cholesterol, poor diet, excessive ETOH or alcohol consumption, obesity, sedentary lifestyle, emotional stress, and smoking. So please know those risk factors, all these risk factors discussed. Now, clinical presentation or cues. So what are the signs and symptoms of patient who may have CAD? So usually these patients may come in complaining of chest pain. They will describe it as crushing, heavy pressure. They may feel tightness on their chest. They may complain of nausea. And then location, usually they'll complain of the chest pain or discomfort in the sternal area, in the jaw, left arm, intrascapular, so around the back area, and then back. Now the patterns can be different. They may describe a precipitating factor or something that can kind of trigger it. Duration may vary. And then also, for depending on what's going on with the patient, there may be some things that can relieve their symptoms. Now, there are drugs used for coronary artery disease, and please memorize this. So you have your MONA, M-O-N-A. So morphine, oxygen, nitroglycerin, and aspirin. So these are medications that we use for coronary artery disease. So if you have a patient having chest pain, these are your interventions usually. Morphine, you give patient oxygen, and you give patient nitroglycerin and aspirin. So morphine really, it decreases the oxygen demand. It helps with the pain. And then oxygen, obviously, it provides supplemental oxygen, which may be needed, especially if we have a problem with oxygenation because of the lack of perfusion. And then you also have nitroglycerin, and nitroglycerin actually causes vasodilation, so it opens the vessels, allowing for more blood to flow in the heart muscles. And then aspirin, it prevents platelets from sticking together, so it prevents clots from forming, or if there's already an existing clot, it prevents it from getting larger. So you have angina, or basically that's the term that we use for chest pain. So there are different types of chest pain, and it will depend on the description. So we have stable angina pectoris, we have prinzmetal or variant angina, and you also have unstable angina or USA. So for stable angina, This is basically temporary and reversible and usually has the same pattern. So it is caused by coronary ischemia, and it's usually brought by a trigger. So it's caused by something, and usually this is very predictable. So examples of this is chest pain when a patient is exercising or maybe smoking, having sexual intercourse, or maybe when they're taking some stimulants or cocaine. And then occasionally anemia can also trigger chest pain. Now, usually the pain generally goes down once those precipitating factors or triggers are eliminated or stopped. So usually this is treated medically with medication and also by anticipating triggers and maybe avoiding them, especially if the patient already knows what triggers their chest pain. Another type of angina or chest pain is Prinzmetal or variant angina. So this is caused by vasospasming of the vessels in the heart, and then this can cause coronary ischemia. And this is often seen with patients who have vascular issues such as migraines and Raynaud's. And going back to what we've learned, right? What do we use to treat migraines and Raynaud's? Well, the first line of treatment for Prinzmetal or variant angina, just given the nature, right, of how it happens, right, because of those spasming, we give them calcium channel blockers. And so calcium channel blockers, right, they relax the vessels, right, so it prevents or helps with that vasospasming. And also we give them nitrates. So calcium channel blockers and nitrates allows for the opening or relaxation of the vessels, therefore preventing those vasospasms that can cause ischemia. Another one, so last but not the least, we have unstable anginas or unstable angina or USA. So this is due to coronary artery atherosclerosis or plaque rupture. So this is when a rupture basically gets loose and clogs the coronary artery. So usually this is acute. It's usually new onset. The pain is quite intense, and even at rest, or it doesn't matter what the patient is doing, regardless of what the patient is doing, this can happen. And this is often unpredictable. It doesn't really have a pattern, just like the stable angina pectoris.